So where we left off yesterday was we just started finishing talking about the idea of hypomobility in the shoulder. And remember that that can be caused by a lot of different things. So it could be OA, it could be RA, it could be the patient who's had immobilization due to surgery, trauma to the shoulder, fracture to the shoulder, and that kind of stuff. All of those things kind of can contribute to a patient having that capsular pattern where external rotation is definitely the most limited, followed by abduction, and then typically internal rotation and flexion are going to be the third limitation in there, typically internal rotation. But with those, we can also get a condition known as frozen shoulder or adhesive capsulitis. So that's actually the answer to this question 19, is asking which of the following diagnoses is characterized by. And if you notice in that list of symptoms there, a couple of things should stand out, and that would be fibrous synovial adhesions and reduction of the joint cavity. And that's definitely your hallmark of adhesive capsulitis. I know you guys have heard of frozen shoulder before, but it's got a couple other names to it. So besides adhesive capsulitis, it's also known as periarthritis. And the weird thing about frozen shoulder is that it can typically occur just kind of spontaneously, not really any known cause, and that would be considered to be primary adhesive capsulitis or primary frozen shoulder. It's a little bit more common in females than males. Middle age is pretty typical for that. It's also more common in diabetics, and it's more common to occur in the non-dominant upper extremity. So besides those kind of insidious, spontaneous onsets, you can also get secondary periarthritis or frozen shoulder or adhesive capsulitis. All those terms basically mean the same thing. And that's usually following some kind of immobilization or trauma to the shoulder. So for example, somebody who had to be immobilized for a while, probably the most common that I've seen is your elderly patient who has a fractured proximal humerus. They typically do not do surgery for those patients, and so their treatment is immobilization in a sling for several weeks. So they are very, very high risk because we're not allowed to move the shoulder, and so they're very high risk for frozen shoulder to develop. So that would be an example of secondary when it happens because of immobilization. Another common thing would be there is some kind of trauma, no fractures, not necessarily a labral tear or anything like that. Person falls, kind of just torques their shoulder a little bit, and then over the coming days after that, they begin to develop a really painful and stiff shoulder, and so they end up with almost complete limitations in range of motion. You'll see the range of motion limitations there follows that same capsular pattern that we've talked about. And the problem with frozen shoulder is that you really see those activity limitations and participation restrictions in patients. So even though it's more typical to be the non-dominant arm, simple things like making a bed, vacuuming, lifting your arm up into the cupboard to get a glass out, or use both arms to lift something up, can be really, really tough for patients, just because, especially in the early stages, everything that they try to do and move that arm, not only can they not move it, but it's very painful when they try to do so. And then even thinking about out in the community, driving is going to be difficult, giving up leisure activities like golf, or if the patient is still working, there aren't too many jobs out there where you don't have to use your upper extremities, and so that can definitely lead to a lot of issues with patients, because when you look at that age range there, you have a lot of people developing this who are still in the workforce. You can see the interventions there, and joint mobilization is definitely an important part of treatment. That's going to have to be for the glenohumeral and the scapulothoracic joint. We've got to make sure that we've got good scapulohumeral rhythm when the patient is elevating that arm, especially above 90 degrees. And you can do things that will help that shoulder, like with the Codman/pendulum exercises, pulleys. Wand exercises are really good to do because you can use that uninvolved upper extremity to help kind of put a stretch on the involved upper extremity. And so early on, we definitely want to try to go within a pain-free range of motion. We've got to remember posture. We got to remember we can use PNF to help with soft tissue lengthening. So we're working the joint, we're working soft tissues in order to gain that range of motion back. And then usually what's easiest for patients as we want to begin strengthening is going to be isometrics. And so in lab, we'll also do isometrics through the available range of motion on a practice patient that we'll have with each other. Progression of exercises would be strengthening, of course, going into closed chain. Finally, take a look there too on the self-mobilization exercises, because those are in your handout. Those are going to be great ones to give a patient to do at home. They can really help with improving range of motion and also improving flexibility. Non-PT wise, sometimes they'll do a steroid injection, and sometimes I'll see where they'll do a steroid injection and they're doing that in order for the patient to tolerate PT better. But in really significant severe cases where PT maybe isn't helping, they may actually have to go in and do a manipulation on that shoulder. Okay, the next condition that I want to talk about is what's known as CTA, or cuff tear arthropathy. And this is also more common in women, especially elderly women. Your symptoms would kind of be similar to a frozen shoulder, except for typical main complaint is pain. So they still can elevate the arm, they can still use it. They've probably lost some range of motion, but they also might have some recurrent swelling in there as well. What we have to remember or understand about this condition is that basically what has happened is that the joint is starting to be destroyed. They typically have arthritis in the glenohumeral joint, and over time that arthritis, those bone spurs, typically maybe they're a patient that had chronic impingement that really didn't seem to get better. They actually end up with tears, especially of the supraspinatus and the infraspinatus muscle. And because of that, those muscles really begin to atrophy. And the atrophy that we notice might not necessarily be palpable. You might be able to tell that it's atrophied compared to the other side, but what typically happens is that fat actually replaces that muscle tissue. And so these are patients that is pretty tough to rehab, because you don't really have any appreciable strength to work with, especially if you've got significant tears within that rotator cuff. So they may go in with a scope and kind of clean it out, get rid of bone spurs, help with the inflammation and that type of stuff. Severe cases, they might even do a shoulder fusion, which can help with the pain. But a lot of times, if they're a candidate for it, what they're really often is a good treatment of choice from that orthopedic surgeon is to do a reverse total shoulder arthroplasty. So let's talk a little bit, first of all, in general about shoulder replacement, or hemiarthroplasty or total shoulder arthroplasty. You can have actually two types. So you have your total shoulder, similar to a total hip. In this case, both aspects of the joint are replaced, the glenoid and the humeral head. Or you can have the hemiarthroplasty, which would be the humeral head only. And the same reasons would apply as far as why one of those would be better than the other for the patient. Just depends on where the pathology is in the shoulder. So this is a patient who has severe pain or instability, decreased function from rheumatoid arthritis or osteoarthritis. These patients who get a regular total shoulder, they have to have a pretty good rotator cuff. So they can't have tears of the rotator cuff, especially not full tears. There definitely patients can benefit from having the arthroplasties if they have pretty severe comminuted humerus fractures, patients that maybe had a humerus fracture or a glenoid fracture, underwent ORIF and ended up with avascular necrosis of the humeral head. Obviously then a shoulder replacement would be indicated in that case, especially the hemiarthroplasty. And then long-term steroid use in patients has been shown to basically break down the shoulder joint. And so sometimes you'll get patients with, chronic steroid use due to breathing issues, breathing conditions like COPD, and they end up needing to have a shoulder replacement. And then of course osteoporosis. It's not going to be hugely common that you get a lot of osteoporosis affecting the shoulder joint, but it definitely can be affected to the point where the shoulder replacement is the best treatment for that patient. Okay, so let's contrast a little bit here, because that was just talking about regular shoulder replacements, but here you can kind of see the difference from doing that regular total shoulder, and again that would count as a hemiarthroplasty on the left hand side as well, versus doing the reverse total shoulder. So let's talk a little bit about who's the candidate. In the total shoulder, you've usually got your degenerative joint disease. It's an older patient. Like we talked about, they might have rheumatoid arthritis or even osteoarthritis, but their rotator cuff is intact. They have arthritis in there, but the loss of motion, the loss of function is there. You can think about it the same way that you do with a total hip replacement. This is a patient whose functional mobility, their activity limitations, participation restrictions, and they really do not have much more of a treatment to find relief from that other than getting a shoulder replacement. Complex fractures, sometimes just like in the hip, if the shoulder is fractured enough, it's really not repairable. By the time you put all that hardware in there, you basically have ended up with a shoulder that would not move at all anyway. So rather than an RIF of several area fractures, they may just decide to do a shoulder arthroplasty as well. And like we said, that cuff has to be good for those patients. Okay, what was happening is for years, patients even without the intact rotator cuff were getting a regular total shoulder replacement, and they were finding that their outcomes were very, very poor. And so when the reverse total shoulder came along, it really kind of threw some people for a loop, because basically what happens is that orientation of the shoulder girdle is reversed. So you think about where your humeral head and where your glenoid cavity are, and now you've got to reverse those. So let's actually look ahead and take a look at what a reverse total shoulder would look like. So there's a nice x-ray that really shows you, okay, we have a difference here now. In an open chain position, look what's actually happening. You've got concave moving on convex. So it kind of changes up the whole dimensions of the shoulder joint as far as what is happening with the concave convex rule. Okay, so another good candidate would be joint arthritis, but that rotator cuff, like we said, not intact. It's probably one they've got that cuff tear arthropathy. It's usually an elderly patient and what they'll call a low demand patient. In other words, this isn't a patient wanting to get back to, playing tennis at age 65 or something like that. It's not a patient that really has to get back close to full range of motion. They just want less pain. They want to improve their motion and, get their life back as far as that pain goes and things like that. So you can kind of read the writing on the wall that with a reverse total shoulder, your outcomes are not going to be 180 degrees of shoulder flexion and abduction and full external rotation. But your range of motion is going to end up functional for the things that you have to do every day in life. Now, also keep in mind that with a total shoulder, you're probably not going to get back those extremes of full range of motion either. It's just too complicated of a joint for you to get back full. But definitely in your reverse total shoulder, you don't get back the range that you do in a regular total shoulder. Okay, so you can kind of see the differences there as far as when one would be done versus another. And that would be an example of the types of fractures. So you actually have like a humeral head fracture. I actually put in the wrong part of that slide. As you can see on the right hand side, that actually shows femoral neck fracture, but I want you to kind of see there would be similar types of fractures that could occur in the shoulder joint at the area of the rotator cuff insertion, like the greater and the lesser tubercle and things like that. The picture there is a little bit complicated, but it kind of shows some real basics, and I'm actually going to go through with you guys in class kind of a sample protocol of what a patient would go through when they have a total shoulder or a reverse total shoulder. There's actually a couple orthopedic doctors around the Quad Cities who typically don't refer their reverse total shoulder patients to therapy, or at least right away they don't. They might have restrictions of a sling for a week or two, and then after that it's just kind of up to the patient to rehab themselves, or they might spend the first month or so out of therapy and then start therapy up again once the healing has occurred to a greater degree and they're ready to start some therapy. But I don't know that studies have really shown that a lot of patients can't just do just as well themselves going through their own rehab or with a home exercise program rather than having to go to consistent therapy sessions after a reverse total shoulder. Okay, so definitely Lou would probably be able to explain this to a biomechanical level that is beyond my scope of thinking, but the basic premise for how this reverse total shoulder works is that it places the deltoid at some type of a mechanical advantage to compensate basically for the fact that rotator cuff is deficient and it's atrophied. So it's supposed to be a lot more stable for this elderly patient without much of a rotator cuff, and it's supposed to help prevent what a lot of times is the problem in the first place, and that's that humeral head migrating in a proximal or superior direction. Okay. These patients, like we said, they have higher complication rates overall, but in general, they tend to do very well. They definitely have permanent restrictions. There's your typical range of motion that they might get. Some patients are going to do better than that. Some patients, that's not going to be achievable, but typically they'll have well over 90, so they can get to about 110 degrees of flexion and abduction. And 30 degrees of external rotation, although that doesn't sound like that much, it's pretty functional for getting dressed, for putting your hand, behind, close to behind your head, behind your back, the rotation that's involved in everyday ADLs and that type of stuff. So turns out pretty good, and probably the biggest thing is pain is decreased for these patients. Next disorder I want to talk about in the shoulder is reflex sympathetic dystrophy, and that's also known as shoulder hand syndrome, or it could be called complex regional pain syndrome. And this will actually come back to us again in the spring semester when we talk about it with CVA, because it is a neurovascular disorder and it does tend to happen after CVA. There's other conditions that it can be associated with, but definitely in some of your neurological conditions like CVA that can actually occur as a complication of the upper extremity for those patients. Basically, this patient has significant upper extremity pain. They're also very, very hypersensitive. So they have hyperesthesia at the shoulder, even running down into the wrist, forearm, and the hand. And the strange thing about this is that it is actually a sympathetic nervous system issue. And what is basically happening is vasoconstriction. So this patient has pain. The pain is pretty much constant and at rest. So special tests, resisted isometrics, we're not really going to be able to reproduce the pain for the patient, other than they're going to have more pain if they're pretty sensitive to touch. So you might even get patients who are so sensitive that they, putting on a heavy sweater is just too much for them on that upper extremity. They feel like sometimes the limb is on fire, like it's burning. Because there's vasoconstriction going on, there's usually a lot of discoloration at the wrist and the hand. The hand will start looking a little dusky and dark. There could be edema in that hand and the wrist area especially. And then because things are so painful, they kind of just develop that disuse pattern of that upper extremity. And so they start not moving. So we begin to get limited range of motion as well. A lot of times they will have changes in hair growth. So more typical is that they used to have hair and now they don't. Or they may actually, you might find that their skin, they perspire or they sweat a little bit more from that upper extremity, changes in that as well. And like I said, they're very hypersensitive, so our touch to them can be very, very painful. I had a lady one time who got some relief with pool therapy due to her RSD, and I just had to make sure to schedule her in the pool when another patient wasn't in there, because even just a little extra ripple of the water when she wasn't expecting it could really bother her, just during the treatment session and stuff like that. So the skin can become kind of really cyanotic and shiny. We begin to get muscle atrophy as well. We begin to maybe have nail color changes where the nails look dark. They look almost bluish or whitish, just because we're not getting good circulation to that upper extremity. Okay, so I already said it could happen after a CVA. There's a little higher tendency after an MI. No one that I know of or anything that I've ever tried to research or find would ever tell us why that would be after an MI or a CVA, but we do have to remember that this is a sympathetic nervous system problem. So it's probably not as clearly understood as we would hope it would be in order to really effectively be able to treat it with physical therapy. The other patients that might get it would be like after a fracture to the upper extremity or a soft tissue injury. We actually had a student in the program several years ago who, when she started the program, she was still kind of recovering from RSD. She had fractured her scaphoid, fell down and hit her hand and fractured her scaphoid, and ended up with RSD of the upper extremity. And to me, that was probably the strangest case I'd ever seen, because when I've seen it with fractures, it's usually been more of a shoulder fracture that causes it to occur. Treatment medically is lots of meds, of course, for pain, and then they may go in and actually do sympathetic nerve blocks for these patients in order to help treat and decrease that pain. Physical therapy can help. Sometimes modalities will give the patient some relief. Getting rid of the fluid with elevation and compression in that upper extremity, wrapping the upper extremity, or even doing a compression treatment on it can help. Sometimes desensitizing it or working with gentle massage and soft tissue can help, but it can be a really, really difficult condition to treat. The hardest part is when it's gotten to the point where the patient is really limited in range of motion, where they almost have like a frozen shoulder because they just haven't been moving it, and because the condition has caused so much pain when they do move it. Okay, our next topic is shoulder instability, and this would include dislocations and subluxations that can occur in the shoulder. In contrast to the hip, anterior is going to be more commonly dislocated than in a posterior direction, and it is a lot more common to dislocate the shoulder than it is the hip. Obviously, the hip is a lot more of a structured joint. It has a deeper labrum. There's just a lot more supportive structures. The hip is definitely more of a stable ball and socket joint than the shoulder is, and so we see more dislocations and subluxations that occur in the shoulder than we do the hip area. It's more common in males also. The problem with dislocating a shoulder is that a lot of times we get associated injuries with it. So we could have injury to the humeral head. We can get what they call a Hill-Sachs lesion, which is basically when you get impaction. So it's basically like a compression fracture of the humeral head into the glenoid cavity. And so along with that, you're probably going to get things like a labral injury as well. A Bankart lesion is what is known as an anterior labrum injury. And then probably the more common, or the one that you especially want to pay most attention to, is what we call a slap tear. And that just stands for superior labral tear from anterior to posterior. Patients that have that kind of a tear, this can actually lead to problems with subluxation or dislocation. So, here's the deal. You can dislocate and cause a labral injury, or you can have a labral injury and this can cause a subluxation or a dislocation. Sometimes the fracture in the shoulder can actually occur right at the rim of the glenoid. That might go hand in hand as well with a labral tear. The greater tuberosity is susceptible to fractures, even avulsion fractures, where actually a piece of the tendon is pulled away from the bone, and greater tuberosity would most obviously be those sit muscles that can tear with it. Rotator cuff tears might occur when you have a dislocation, and then sometimes neurologically things like the axillary nerve can have damage to it. More common in the elderly might also be vascular injuries like subclavian area and injuries to the axillary artery and stuff like that, but that's not going to be as common. So that's the kind of the problem with especially full dislocations, is that it's not just, oh, you dislocated, let's put it back in. There's probably going to be some damage somewhere else within the shoulder. There's some good pictures, I think, of the slap tear and then the Bankart lesion. And when you look at the two pictures on the right-hand side, that would be what's considered that Hill-Sachs lesion. You can kind of see the damage that would be done to the humeral head in that case. And so those are probably going to be your more common injuries that we hear of and that are definitely going to need some repair. So if we're talking about non-operative management of a shoulder dislocation, it's usually going to be closed reduction. So they're going to put it back in place, followed by immobilization. Again, depending on that patient and depending on their age, that could be approximately 3 weeks. It also might depend on how conservative or not conservative that ortho is. And we will actually watch a video that shows how they put back in a shoulder. Acute-wise, though, when it comes to PT, so this is a patient that, again, didn't need surgery or anything like that, the sling is going to be removed in order to do range of motion of those distal joints. Ice is always a friend because it will help with pain and it will help with decreasing inflammation and swelling. Even E-stim might be a good idea for these patients if they're still having a lot of pain. They might be allowed to do submaximal isometrics, but usually in the sling during those first few weeks if they're still in it. And then scapular exercises are going to be really, really important, especially to work those scapular stabilizers. So what you really need to avoid early on is what we would call that motion of dislocation, and that would be that combination of the shoulder being an abduction and external rotation. So just kind of think about the position as if you were going to throw a ball. So the shoulder is abducted to about 90 degrees and you're going into full external rotation. That would be about the worst thing that you can do. And that's assuming that the dislocation was in an anterior direction, which is going to be hugely a lot more common. Progression-wise, then we can start doing range of motion. We still might be told we have limitations for how far we can push into that motion of abduction with external rotation, but we can definitely start some gentle joint mobilization, Codman's exercises, pulleys, wand, real basic stuff like what we've seen already. Just gently stretching out the shoulder, making sure we're getting good elevation, good scapulohumeral rhythm, and that type of thing. But again, keeping in mind that we may have limitations in how far we can take them into that motion of dislocation. Finally, towards the end stages, we can begin resistance, we'll begin closed chain stuff, working on balance board, plyo ball. If this is an athlete, we're going to get them back to sports-specific activities and that kind of stuff. So it really, when it happens and people can get rehab through it, they do pretty darn well. Here would be a pretty simple boards question. I'm going to let you read it. Okay. And hopefully, as you've read that, you are going to pick C, modify the exercises to accommodate limitations of motion and pain. Okay, so what about the patient who has shoulder instability? They've probably dislocated the shoulder on numerous occasions. It's kind of a chronic issue for them. This surgery can be done both in an open format or it can be done with arthroscopy. So that kind of makes a recovery a lot nicer if it doesn't have to be an open surgery for it. But a lot of that will depend on what other damages there are in the shoulder. So if they have to do things like repair the labrum or reattach the capsule, that in itself might take a lot more invasive type of surgery, and it might have to be done with an open incision versus just going in with a scope. I've got a couple of videos that I'm going to post on Canvas that are really helpful to kind of see how different shoulder surgeries are done, with a labral tear being one of them. Initially, patients are going to have immobilization. Your progression is exactly similar to what we already talked about for non-operative treatment. If you have somebody who has a dislocation and they undergo therapy after immobilization but no surgery, you're going to see that same sort of progression. We probably are going to see, though, that it's going to be a little bit slower. So the surgical procedure will dictate what we're allowed to do. The surgeon will dictate how much motion we're allowed at first, and typical, as is always with most of our shoulder conditions, external rotation is going to be the slowest to gain back. Okay, within the shoulder, we can't forget that we don't just have glenohumeral joint as our main player in there. We also have the AC joint. So as far as AC sprains and dislocations, typical for patients to have this, it's usually a younger patient. They fall either directly on that acromion, maybe a sports-related injury, football tackle, that kind of stuff, or they fall and their arm is outstretched to catch themselves, but they end up having a sprain or a dislocation of the AC joint. An older person does that, they fall on their outstretched arm, and they're probably going to get a Colles fracture of the wrist. Younger patient or middle-aged person does it, and more common would be that we're going to see issues at that AC joint. So you can look at those grades, and those are different than how we've learned grades in the past when it comes to ligament tears. And so the grade 1, grade 2, grade 3 is basically just made up of what is actually torn. Is it a partial tear? Do we have a complete rupture? So each of those in itself has a much higher degree of severity as far as pain and things like that. One of the things to note, though, besides worrying about which ligaments we're talking about, the difference in the grade 2 and grade 3 there is you're going to have in a grade 2 kind of a little gap between the acromion and the clavicle, but within a grade 3, because now both AC and CA ligaments are completely ruptured. This is the patient that not only has severe pain, range of motion limitations, but they would have what we call a step off at the clavicle and the acromion. In other words, you can see physically that separation pretty easily, and that's typical because the clavicle is usually going to be displaced in a superior direction when it comes to that type of grade 3. So there's kind of your treatments. A grade 1, we really don't have to do a whole lot other than it might be for symptoms of pain and swelling. They're going to get back out to playing, doing whatever activity pretty quickly when it's just a grade 1. Grade 2, though, they're probably going to have to be in a sling, and that might be up to a month, month and a half, and that's just basically to approximate those ligaments back together. You're talking ice, of course, maybe ultrasound TENS is going to be kind of common. Patients have a lot of pain. All we can really do at first is submaximal isometrics. Once we're allowed and out of the immobilizer, active range of motion can be started. Patient will be able to progress, just like we talked about in the past, get their active range of motion, begin resistive exercises, closed chain stuff. And your biggest thing that you're doing at first is you're just avoiding any movements that distract the AC joint. So obviously patients like this, you wouldn't want to do things like necessarily pendulum exercises or a lot of dependent exercises because we want to avoid those motions. For grade 3s, people can go the non-operative route, but they will be immobilized for up to 6 weeks. We have to remember how poorly ligaments heal due to blood supply. So your treatment progression is going to be similar to what we talked about with grade 2, but it's going to go pretty slow. Most people trying to get back to their function, to their life, to their sport, if they have a grade 3, they're probably going to undergo surgical repair for that. And so that can involve any type of an ORIF, using a pin, sutures. They may have to do something to excise part of the clavicle and stuff like that, or a reconstructive type of surgery. Whatever the case might be, our progression is going to be similar, but with those, we also want to remember that we're allowed to do certain range of motion, depending on the surgeon, and we've got to follow that protocol as well. Okay, it wouldn't be right to talk about the shoulder and not talk about other areas that are fractured, like the scapula. And so when you look at scapular fractures, they're not going to be hugely common, but when they do happen, they are usually because of direct trauma right over that scapular area. So it could be the body of the scapula, it could be like a glenoid neck type of fracture that can be affected. And so most of the time, these are not surgical. These are going to be immobilization for a while, progress as we've been talking about all along already as you've been listening to me today. And so with those, again, surgical fixation would be a rarity, but if they have to do that, it's usually because it's a comminuted or kind of an unstable fracture. Clavicle can be fractured. That's usually just traumatic in nature, so it's direct or indirect trauma to that area. They'll usually do sometimes just a figure-8 splint, and I have a picture of that, just to reduce it and to provide some stability. And you can see that progression there that we're going to follow in lab for a particular case is pretty applicable to a lot of these shoulder and associated type of injuries that we've been talking about today. There's your figure-8 brace. Proximal humeral fractures, and that can include not only the actual shaft of the humerus, but it could be the humeral head, greater or lesser tuberosity, or tubercle, whatever you like to call it. And with those, most common, especially for the elderly, if it's a pretty simple, clean, not displaced type of fracture, they'll usually just put them in an immobilizer. But unfortunately, that can be for several weeks. And with that, we've got to make sure they're moving that elbow, that wrist, that hand. They're squeezing that ball, doing whatever they can while they're in that immobilizer, because we've got a big job ahead of us once they get out of that immobilizer. And it's going to be hard, at least initially, getting back that shoulder range of motion. If they do go in and do surgery, it's an ORIF, and they'll progress with isometrics and things like that. Usually with an ORIF, you might have a period of immobilization first. It won't quite be as long as when they manage it conservatively without surgery, but your progression is going to be pretty similar. We have to remember that because this joint is similar to the hip joint, we've got a lot of the same types of complications that can occur. So avascular necrosis could definitely be a risk for patients. Severe fractures, patients with comminuted, just shattering type of fractures, your elderly that have osteoporosis and things like that, that shoulder replacement might be the best treatment of choice from that ortho. And then we have to make sure that when we're getting back range of motion, we're getting back that good SH rhythm, that scapulohumeral rhythm. And as with all patients, they are going to be at risk for elbow, wrist, hand tightening up on them. So continue to do those types of exercises, or at least as part of a home exercise program for those patients. There's another boards question. Oh, and I'm sorry, I put in the same question twice. Didn't mean to do that. So if you didn't answer C right last time, you got it right this time. It would be C. The next slides just show some of the special tests that we're going to do. We're going to do a lot of tests that are for impingement of the shoulder, but we're also going to do a couple of tests that help determine if a labral tear might be possible with a patient. So I've got a few of them. This is for tendency for shoulder dislocation, the anterior apprehension test. Empty can test looks for supraspinatus, tendonitis, and I've got a couple other ones that I don't necessarily have pictures of that we'll be doing in lab. So hopefully that helps to learn about those diagnoses, and I will see you guys in lab on Tuesday. Have a great day. Bye.